Hello friends, in this video we'll study about angiography, that is imaging of the blood vessels. So when you're looking at the vessels, if the contrast inside the vessels is appearing dark, that is a digital subtraction angiography or a catheter angiography. I hope you can see there is a catheter inside the aorta and you inject the contrast and take the x-rays here. So basically this is catheter angiography or a digital subtraction angiography. Now what do you mean by this subtraction? What is being subtracted? In digital subtraction angiography, a pre-contrast X-ray is subtracted from a post-contrast X-ray. That is what is a subtraction here. And because we have to do it by putting a catheter inside the vessel and injecting the contrast, it is also called as a catheter angiography. But if the contrast inside the blood vessels is white, this can be either a CT angiography or a MR angiography. Look at the bones and decide that. If the cortical bone is white, that is CT angiography. We all know bone is white on CT, bone is white on CT. Whereas if the bone is dark, that is MR angiography, the bones are dark on MRI. So is it a CT angiography or MR angiography? Now look at this image. What do you think is this? Is it a CT angiography or MR angiography or a digital subtraction angiography? You can see that the contrast inside the blood vessels is dark. This is a digital subtraction angiography of the internal carotid artery, showing the anterior cerebral artery and the middle cerebral artery, the branches of internal carotid artery. And through which vessel do we enter into the carotids? What is the axis through which we are entering inside the carotids? The intra-arterial axis. Intra-arterial axis is mainly through the transfemoral route. Transfemoral route. So we enter the vessels through the femoral artery, enter into the femoral artery, then the external iliac, common iliac, the abdominal aorta, go up above into the arch of aorta. From there we get the carotids originating. So the intra-arterial axis is mainly through the femoral artery. This is a digital subtraction angiography or catheter angiography of the vertebral artery, of the left vertebral artery. You can see the vessels here. This is the basilar artery, which is dividing into the two posterior cerebral arteries. So this is the left vertebral artery, and that is coming and forming the basilar artery, which is dividing into the two posterior cerebral arteries. You can see an aneurysm at the tip of the basilar artery. This is basilar tip aneurysm. You are seeing in this image, there is a basilar tip aneurysm. And now look at this image. Here also you are seeing an aneurysm located at the internal carotid artery. Before it branching out into anterior cerebral and middle cerebral, the internal carotid artery is showing an aneurysm. And what is a gold standard investigation to know the site of aneurysm? Where is it located? Is it located in the posterior circulation, anterior circulation? Is it in the ACOM area, PCOM area, anterior cerebral artery, middle cerebral artery, posterior cerebral artery? To know where is the actual site of the aneurysm, we need to go for 4-vessel angiography. And what are the 4 vessels are we trying to image? What are the anterior part of circular villus formed by? The 2 internal carotid artery. The anterior part of circular villus is formed by the 2 internal carotid artery. And what is forming the posterior part of circular villus? The posterior part of circular villus is formed by the 2 vertebral artery. So when you catheterize the 2 internal carotid artery and the vertebral artery, you get a 4-vessel angiography. You can know where is the site of aneurysm in the circular villus. And to know the site of rupture of aneurysm, where is the rupture has occurred? The patient is having a worst headache, thunderclap headache. Remember, aneurysm rupture leads to subarachnoid hemorrhage. The aneurysm rupture leads to subarachnoid hemorrhage. To know where is the site of the aneurysm rupture that is occurring, and in acute setting, when the patient already has a worst headache of his life, we don't have much time to plan for a 4-vessel angiography or a MR angiography. We need to be getting the location much faster. We go for CT angiography. So to know the site of aneurysm in an acute setting, we go for CT angiography. But if you're doing imaging to look for where the aneurysm is, it's not an acute setting, you're looking for a screening of aneurysm. For example, you have a ADPKD patient, adult polycystic kidney disease patient. You want to know whether this person has an aneurysm or not. You're screening for aneurysm in that patient. You have time. There is no symptoms in the patient. There is not an acute setting that you're dealing with. You have time. And we know MRA is time consuming, but a better imaging for neurovascular imaging. So for screening of aneurysm, what would be better? MR angiography would be better. MR angiography. So the gold standard is actually a catheter angiography, that is 4-vessel angiography. The gold standard to know the site of aneurysm. In acute setting, what is preferred? A CT angiography. For screening of aneurysm, what is preferred? MR angiography. And when you find out the aneurysm is there, how do you manage it? What is the treatment of aneurysm? The treatment of aneurysm is through endovascular coiling. Endovascular coiling. So you can see here, this is how the endovascular coiling is done. And you can also go for surgical clipping. So either you do a endovascular coiling, this is preferred method done by the interventional radiologist, or you can go for a surgical clipping. So endovascular coiling, this is how a endovascular coiling is done. This is endovascular coiling that is being done for aneurysm. Right? Now look at this image. This is an MR angiography image showing the circular bullous. You can see this is the basilar artery, which is dividing into the two posterior cerebral arteries. These are your internal carotid arteries, which are then dividing into the anterior cerebral artery and the middle cerebral artery. So the internal carotid artery is dividing into an anterior and middle cerebral artery. They are forming the anterior part of circular bullous. So here this is the middle cerebral artery and this is the internal carotid artery. How do we differentiate an internal carotid artery from a middle cerebral artery on the imaging? Remember, to differentiate an internal carotid artery from the middle cerebral artery, look for the vessel present in the sylvian fissure. The vessel that is present in the sylvian fissure and going and branching out like this on the superior lateral surface of the brain, that is your middle cerebral artery. The artery located in the sylvian fissure and branching out on the superior lateral surface of the brain, that is your middle cerebral artery. And this vessel that is joining the two anterior cerebral artery, this is anterior communicating artery. And this vessel, which is coming from the internal carotid artery and joining the internal carotid to posterior cerebral, this is the posterior cerebral artery, and joining the internal carotid and the posterior cerebral is your posterior communicating artery. Let me zoom it for you once again. Please remember, the posterior communicating artery is a branch of internal carotid artery. Posterior communicating artery is a branch of internal carotid artery joining the internal carotid artery with the posterior cerebral artery. So this is the parts of the circle of Willis on MR angiography. Here I have shown you a labeled image to understand the vessels once again, which is basilar artery, the posterior cerebral artery, the internal carotid artery dividing into anterior cerebral and middle cerebral. The middle cerebral passes in the sylvian fissure, branches out on the superior lateral surface of the brain. The artery that is joining the two anterior cerebral artery is anterior communicating artery. Posterior communicating artery is coming from the internal carotid artery and joins the internal carotid artery to the posterior cerebral artery. The imaging of the vessels by MRI, the MR angiography, can be done by either giving gadolinium contrast or without contrast also. Remember, gadolinium is toxic. It cannot be given in kidney pathologies. It produces nephrogenic systemic fibrosis. And gadolinium is teratogenic. You cannot give it in pregnancy, right? So people who are having kidney pathologies, people who are pregnant, for these patients, if you want to look at the cerebral vessels, I cannot do a gadolinium based MR angiography. I have to go for a technique which is non-contrast. And such a imaging technique which is MR angiography without contrast, this is called as time of flight technique. So in time of flight technique, it is a software that picks up the incoming H plus ion without having to give gadolinium from outside. Only the incoming H plus ion in that area are picked up and the vessels are imaged accordingly. So this technique, which looks at the incoming H plus ion into the area without having to give contrast from outside, that is called as time of flight technique. So remember, time of flight technique is MR angiography without contrast. MR angiography without contrast. Normally, how do flowing blood vessels appear? How does flowing blood appear on MRI? Please remember, flowing blood is a flow void. Flowing blood vessels on MRI, this appear as signal voids. They don't give you signal, they appear as dark areas, right? So if you want to see the vessels, either you have to go for gadolinium or you have to go for time of flight. What do you mean by time of flight? MR angiography without contrast. MR angiography without contrast. Now what do you think is these images showing you? This is your MR venography. This is MR venography, because it is showing you the dural venous sinuses. They are showing the dural venous sinuses. This is the superior sagittal sinus going towards the confluence of sinuses. On either side, you have the transverse. This is the right transverse, this is the left transverse. Then you have the sigmoidal sinuses opening into the jugular vein. So you have a labeled image here. You can understand this better. There is a superior sagittal sinus going towards confluence of sinuses, and from either side you get the transverse sinus going into sigmoid sinus and finally opening into the jugular vein. So you are having this dural venous sinuses. This is MR venography. MR venography. Now please look at this image. This is also MR venography because you are seeing the dual venous sinuses. So this is MR venography. You are seeing a coronal view, right? MR venography. And what do you see here? This is the superior sagittal sinus. This is the right transverse sinus. But the left transverse sinus is missing. There is an absent signal of the left transverse sinus. And this is suggestive of transverse sinus thrombosis. This is left transverse sinus thrombosis. So the same thing is shown here, right? So absent signal in the transverse sinus on MR venography. So you may have a CSOM patient, ear discharge, left ear discharge, and the patient may have this left transverse sinus getting thrombosed. This is called as the Grissinger sign. Remember, Grissinger sign is a lateral sinus thrombosis. Is a lateral sinus thrombosis that occurs in CSOM patients. So that is a Grissinger sign that we have. And what is this image? What is this image showing you? This is also showing you the MR venography, but this MR venography is in a sagittal plane that you are seeing. So this is MR venography. Now, please look at this MR venography. Again, a sagittal view is given of the MR venography. And what are these arrows pointing to? What are these arrows pointing to? Remember, this is a superior anastomotic vein. This is joining the superficial middle cerebral vein to the superior sagittal sinus. This superior anastomotic vein that is joining the superficial middle cerebral vein to the superior sagittal sinus, this is called as vein of Trolad, vein of Trolad. So the top one is the Trolad, vein of Trolad. And another anastomotic vein, but inferior anastomotic vein that is joining the superficial middle cerebral vein with the transverse sinus. This inferior sagittal vein is called as vein of Labbe, vein of Labbe. So the Labbe is the lower one, L. So the vein of Labbe is the lower one. So on MR venography, they can point these areas and ask what are these things. So vein of Trolad is the superior anastomotic vein. Vein of Labbe is the inferior anastomotic vein. Joining which structures? The superficial middle cerebral vein to superior sagittal sinus is vein of Trolad. The superficial middle cerebral vein to transverse sinus is vein of Labbe. Now, please look at this CT and MR images. So, this is a sagittal CT and sagittal MRI. The bones are white on CT. The bone is dark on MRI. And the subcutaneous fat is dark on CT. The fat is white on MRI. So, this is the CT and the MR image. What do you see in this? In the midline, in the brain, there is a vascular swelling. And I told you how does flowing blood appear on MRI? It appears as a signal void. So, this is a flowing blood in the blood vessel. It is appearing like a signal void. Now, what is this image showing you? Now, when you have a child with hydrocephalus, you can see the ventricles are dilated, the lateral ventricles are dilated. When you have a child with hydrocephalus, a midline vascular swelling is seen in the brain. And this child also has congestive heart failure. There is a triad of congestive heart failure, hydrocephalus and midline vascular swelling. This is called as vein of Galen malformation. A child with hydrocephalus, congestive heart failure and midline vascular swelling. Now, exactly what happens is, in the embryonic life, there are these embryonic arteries that are coming and directly opening into this embryonic vein. This is opening into this median prosencephalic vein. This is a median prosencephalic vein. So, this communication, this abnormal communication that we have here, this is the problem. So, what do you think this is? Is it a AV malformation or AV fistula? Now, when you don't have a nidus, when you don't have any coiled vessels, arteries are directly opening into the vein. This is called as a AV fistula. There is no nidus. A AV fistula does not have any coiled area in between. There is no nidus. So, this is AV fistula. So, vein of Galen malformation is a misnomer. It is neither a malformation, and what is dilated is not a vein of Galen. It is a misnomer. So, it is not a AV malformation, it is a AV fistula. Why we are calling it fistula? You don't see a nidus there. and it is not a vein of Galen. What is dilated is an embryonic precursor of vein of Galen, the median prosencephalic vein in the midline, and the median prosencephalon, the forebrain, right, the embryonic life. The median prosencephalic vein is dilated and there is an AV fistula. If you can understand this much, this arrow, if you understand, you will understand everything about vein of Galen malformation. Once again, this is an AV fistula. Once there is an AV fistula, what will happen to preload to the heart? What will happen to the venous return and preload to the heart? Increases. So the child develops congestive heart failure. And this vascular swelling in the brain will compress the aqueduct, will compress the third ventricle, leading to hydrocephalus in the child. So a triad of hydrocephalus, midline vascular swelling and congestive heart failure. And when you use your stethoscope and put it on the head of the child, you can hear the intracranial brewing, the vascular noise in the head. So this is midline vascular swelling causing the intracranial brewing in the patient. So when you have a child with midline vascular swelling, hydrocephalus and congestive heart failure, that is vein of Galen malformation. It is a misnomer. What is dilated is not vein of Galen, it is its embryonic precursor. What is that? That is the median prosencephalic vein, median prosencephalic vein. And it is not a AV malformation, it is an AV fistula. So remember, all of this is vein of Galen malformation. Right? Let's move to the next one. If you have a patient who is having a basal skull fracture and pulsatile proptosis in the patient, so there is a pulsatile proptosis. With each heartbeat, there is pulsation in the orbit. So a basal skull fracture patient developing pulsatile proptosis, on the imaging, you are seeing there is a dilated cavernous sinus and there is also a tortuous dilated superior ophthalmic vein. So if you see a dilated cavernous sinus on either side of the sella, you are seeing the cavernous sinus. On the right side, you can see a prominent cavernous sinus. And the right superior ophthalmic vein also going to the orbit is dilated. So you are seeing a tortuous superior ophthalmic vein. This should make you think of a condition called as keratico-cavernous fistula. Keratico-cavernous fistula. Now, what exactly is happening here is there is a cavernous sinus. And inside the cavernous sinus, we see the internal carotid artery. And you have a cavernous sinus. And there is a communication between the internal carotid artery and the cavernous sinus. So after trauma, there is a communication developing between the internal carotid artery and the cavernous sinus. Now, this connection between the internal carotid artery and cavernous sinus will cause the cavernous sinus to be dilated. And the cavernous sinus is communicating with the orbit through the superior ophthalmic vein. There is a superior ophthalmic vein that is connecting to the orbit. So what will happen? The pulsations of the internal carotid artery will reach through the superior ophthalmic vein into the orbit, causing pulsatile proptosis in the patient. So what are the findings? There is a dilated cavernous sinus, there is a tortuous superior ophthalmic vein and pulsatile proptosis in the patient. What is it due to? It is due to the keratico-cavernous fistula, not cavernous sinus thrombosis. Remember, pulsatile proptosis is not a feature of thrombosis. If there is a thrombosis, the pulsation will not go. If it is a fistula, there is a keratico-cavernous fistula, the pulsations of the internal carotid artery are transmitted into the cavernous sinus, into the superior ophthalmic vein and then into the orbit. So you will see this pulsatile proptosis when you have keratico-cavernous fistula. Now let's understand what a true AV malformation is. If you see this coiled area of blood vessels in the center and there are feeding arteries that are coming into that area and a draining vein coming out of it. So when you see this nidus with feeding arteries and draining vein, so this is what is a true AV malformation. This is true AV malformation. You are seeing a nidus in the between. The coiled area is called as a nidus. This coiled area in the middle is called as a nidus. So this is the nidus that you have. So when you see the nidus, you see the feeding artery and a draining vein out of it. This is a true AV malformation. So nidus and feeding artery, this is suggestive of true AV malformation. But if there is directly the artery communicating with the vein without any nidus, this is called as a AV fistula. In AV fistula, there is no nidus. There is no nidus in AV fistula. So this is what is the difference between AV fistula and a AV malformation. And if you have a patient who is having lobar hemorrhage and his non-traumatic patient, young patient, non-hypertensive patient, A young non-hypertensive patient developing a lobar hemorrhage strongly suspect rupture of AV malformation. So these are congenital malformations, AV malformations. So it generally occurs in a young child, young patient having a lobar hemorrhage, a frontal lobe hemorrhage, a temporal lobe hemorrhage in a young patient who was non-hypertensive, suspect AV malformation rupture. Elderly non-hypertensive patient, non-traumatic patient, developing a lobar hemorrhage. So he developed a frontal lobe hemorrhage or temporal lobe hemorrhage. Suspect cerebral amyloid angiopathy. Elderly non-hypertensive patient developing a lobar hemorrhage. Suspect a cerebral amyloid angiopathy. Whereas a young patient, non-hypertensive, non-traumatic, developing a lobar hemorrhage, suspect AV malformation rupture. And where do you see this caput medusa appearance? A caput medusa appearance is a feature of venous malformation. I hope you can see this caput medusa like flow voids, signal voids that you are seeing. This is venous malformation. Now imagine this is the artery, these are the capillaries. The arteries and the capillaries of the microcirculation are fine. But the problem is on the venous side. There are tortuous veins, serpiginous veins, which are coming and opening into a single large vein. So this is called as a venous malformation. The arterial side is okay, the problem is on the venous side. So this tortuous serpiginous veins are coming and opening into a single large vein, forming a caput medusa like appearance or medusa head appearance on the MRI. So caput medusa or medusa head appearance on MRI of the brain. This is suggestive of which malformation? Venous malformation. Venous malformation has caput medusa or medusa head appearance. And where do we see this popcorn appearance on MRI brain? Such popcorn appearance on MRI brain, this is suggestive of a cavernous angioma. Cavernous angioma. So caput medusa appearance or medusa head appearance on MRI brain is suggestive of venous malformation. A popcorn appearance on MRI brain is suggestive of a cavernous angioma. And I hope you all know the three direct branches of arch of aorta. What are the three direct branches of arch of aorta? You have the brachiocephalic artery, left common carotid, left subclavian, right? So these are the three direct branches of arch of aorta. You will have a brachiocephalic artery on the right side, you will have a left common carotid and a left subclavian. These are the three direct branches of the arch of aorta. But instead of getting three direct branches of the arch of aorta, that is the brachiocephalic artery, left common carotid, left subclavian, if we get two branches from the arch of aorta, and there is a common origin of the brachiocephalic artery, the right brachiocephalic artery and the left common carotid. If they take a common origin, which ones? The left common carotid and right brachiocephalic artery. If they are coming commonly from a single area, single vessel, this is called as bovine arch. So bovine arch is a most common congenital anomaly of arch of aorta. The most common anatomical variant of arch of aorta is the bovine arch. And what is bovine arch basically? It is a common origin of brachiocephalic artery, the right brachiocephalic artery and left common carotid. So you should know the most common anatomical variant of arch of aorta. What is that called? Bovine arch. And what is a bovine arch? A common origin of right brachiocephalic artery and left common carotid. And instead of three direct branches, if you are getting four branches of arch of aorta, you are getting the right common carotid, you are getting the left common carotid and the left subclavian, and the right subclavian is coming below the origin of left subclavian. There is an aberrant right subclavian artery which is coming below the origin of left subclavian. Instead of the brachiocephalic artery, you are directly getting the right common carotid from the arch of aorta, and there is an aberrant right subclavian artery coming below the origin of left subclavian and going all the way posterior to the esophagus, compressing the esophagus posteriorly, causing dysphagia in the patient. This is called as dysphagia lusoria. So you can see the CT scan image here. In the CT scan image, you can see this vessel that is coming posterior to the esophagus. So this anteriorly, this is the luminal area in the trachea, and behind that, I hope you can appreciate the luminal area in the esophagus. So look at it once again. Are you able to see that? There is a trachea and there is a esophagus, and there is a vessel that is passing from the arch of aorta posterior to the esophagus, compressing the esophagus. This is aberrant right subclavian artery. This is dysphagia lusoria. Dysphagia lusoria is due to aberrant right subclavian artery. So what do you think will happen on the barium swallow? Will there be anterior indentation of the esophagus or posterior indentation of esophagus? Because the patient is presenting with dysphagia, you're getting a barium swallow study done. And what do you see on the barium swallow study? There is a posterior indentation of the esophagus. So in dysphagia lusoria, because the aberrant right subclavian artery goes posterior to the esophagus, there will be posterior indentation of esophagus on the barium study. This is dysphagia lusoria. There is posterior indentation of esophagus on the barium swallow. Now let's understand what is a pulmonary sling. Now pulmonary sling, this is an anomalous left pulmonary artery arising from right pulmonary artery. It is anomalous left pulmonary artery arising from right pulmonary artery. Normally we have the main pulmonary artery dividing into right and left pulmonary artery, right? So this is normal. Normally what do we see? We see that the main pulmonary artery is dividing into right pulmonary artery and left pulmonary artery. This is normal. But if the main pulmonary artery only gives rise to right pulmonary artery, this is the main pulmonary artery and it only gives rise to right pulmonary artery. And the left pulmonary artery comes from the right pulmonary artery. This is called as the pulmonary sling. So what is pulmonary sling? It is an anomalous left pulmonary artery arising from right pulmonary artery. Here you can see this is the main pulmonary artery which is giving rise to right pulmonary artery. And the left pulmonary artery is coming from the right pulmonary artery going between the esophagus and the trachea to supply the left lung. So anomalous left pulmonary artery arising from the right pulmonary artery going between the trachea and the esophagus. This is pulmonary sling. Now what do you think pulmonary sling will cause? Anterior indentation of esophagus or posterior indentation of esophagus? Obviously pulmonary sling produces anterior indentation of the upper esophagus. Right, so anterior indentation of the esophagus, this is pulmonary sling. So if I show you the barium study image, this was aberrant right subclavian artery that was producing posterior indentation of esophagus. Wherever the spine is there, that is the posterior part. So aberrant right subclavian artery, that is dysphagia lusoria, is producing posterior indentation of esophagus. Whereas pulmonary sling, that produces anterior indentation of esophagus, pulmonary sling. But if you see an anterior indentation on the lower part of the esophagus, this is suggestive of left atrial enlargement, So remember the most posterior chamber of the heart, where the heart is there, that is left atrium. Even left atrial enlargement produces anterior indentation of esophagus. Pulmonary sling is also producing anterior indentation of esophagus. But dysphagia lusoria, which is due to aberrant right subclavian artery, is producing posterior indentation of esophagus on the barium study. Now let's look at the CT scan images at the level of the mediastinum. So we finished the imaging of the brain. We are trying to understand the imaging of the neck vessels and the mediastinal structures. So in this image, you can see here, this is the right lung, this is the left lung, and here, this is the left-sided aortic arch. This is the left-sided aortic arch. Normally, the aortic arch is on the left side. But here you can see that the aortic arch is on the right side. The aortic arch is on the right side. So this is right-sided aortic arch. And right-sided aortic arch can be seen in a significant number of patients with tetralogy of Fallot. Around 25 to 30% of patients of tetralogy of Fallot will have this right-sided aortic arch. And here you can see there is a duplication. There is a double aortic arch. So you should know the left-sided aortic arch, right-sided aortic arch, and a double aortic arch in the patient. Now let's try to understand what is Al-Kappa. Al-Kappa, basically this is the full form. It means anomalous left coronary artery arising from pulmonary artery. So Al-Kappa is basically anomalous left coronary artery arising from pulmonary artery. Normally, we all know that the both right and left coronary should come from the ascending aorta. The right coronary artery as well as the left coronary artery normally should come from the ascending aorta. They should come from the ascending aorta. But here you can trace the left coronary, it is coming from the pulmonary artery. The left coronary is coming from the pulmonary artery. Such anomalous left coronary artery arising from pulmonary artery is called as Al-Kappa. And pulmonary artery, does it have oxygenated blood or deoxygenated blood? The pulmonary artery, obviously it will have deoxygenated blood. So even the left coronary artery will receive deoxygenated blood. So this will be a child who is more prone to develop MI because the left ventricle, the left auricle, they are being supplied by the left coronary coming from the pulmonary artery carrying the deoxygenated blood. So this will be a child with risk of MI. So you'll have a child with MI in case of Al-Kaaba. When you are given a child with MI, please think of two things. One is anomalous congenital anomaly called as Al-Kaaba, anomalous left coronary artery arising from pulmonary artery. And any other vasculitis you know which can produce child with MI? I hope you all remember, that is Kawasaki's disease, Kawasaki's. So child with MI can be Al-Kaaba or Kawasaki's. Here, this is also a 3D CT image, and I hope you can see the left coronary artery is coming from the pulmonary artery. You can see the pulmonary artery giving origin to the left coronary artery. So, this is a 3D CT image of Al-Kaaba. Al-Kaaba, anomalous left coronary artery arising from pulmonary artery. Now, look at this image here. Here, you are seeing a right inferior pulmonary vein going and opening into the IVC. So, when the right inferior pulmonary vein goes below the diaphragm and opens into the IVC, the lower part is broader. The lower part is broader compared to the upper part because it is opening into a major vessel. The lower part is broad. And what do you call this? This is called as scimitar sign. Scimitar sign. Scimitar is like the Turkish sword, where the upper part is narrower and the lower part is broad. And what is happening in this? The right inferior pulmonary vein, only on the right side, the inferior pulmonary vein is opening into IVC. And what do we also call this? Scimitar sign is seen in partial anomalous pulmonary venous communication. Partial anomalous pulmonary venous communication. This is PAPVC. PAPVC has scimitar sign. What is a scimitar sign? The right inferior pulmonary vein opens into the IVC. The lower part is broader compared to the upper part. And what is this? This is a digital subtraction angiography or a catheter angiography of the abdominal aorta. You can see the blush in the kidneys, right? And you can see the renal arteries. So this is digital subtraction angiography of the abdominal aorta. This is a CT angiography. The bones are white, and this is the CT angio of the abdominal aorta. This is a sagittal view given to you, and you are seeing three ventral branches. You are seeing a celiac trunk. You are seeing a superior mesenteric artery and an inferior mesenteric artery. So from T12 level, the L1 level and L3 level, you get this vessels coming from the abdominal aorta. The celiac trunk, you are having the superior mesenteric artery and the inferior mesenteric artery. Now look at this image here. Here what do you see here is there is a median arcuate ligament that is compressing the celiac trunk and causing hooking of the celiac trunk. So this is called as median arcuate ligament syndrome or MALS, MALS. So the patient has postprandial pain, and on the imaging you will see there is a hooking of the celiac artery. So when you see such hooking of the celiac artery, this is median arcuate ligament syndrome. And this is digital subtraction angiography of celiac trunk. You know the branches of the celiac artery from your anatomy. You see this is the celiac trunk. And what are the three direct branches that you get? You get a common hepatic artery, a left gastric artery, and the splenic artery. The tortuous vessel on the left, this is your splenic artery. The small vessel is the left gastric, supplying the lesser curvature of the stomach. And the common hepatic artery divides into a proper hepatic artery and a gastroduodenal artery. The proper hepatic artery divides into a right hepatic artery and a left hepatic artery. The cystic artery is a branch of right hepatic artery. The cystic artery is a branch of right hepatic artery. So these are the branches of the celiac trunk. So A is celiac trunk. What is B? The small vessel, the left gastric artery. What is C? The vessel on the left side, tortuous vessel going towards the spleen, splenic artery. D is common hepatic artery. E is gastroduodenal artery. And F is proper hepatic artery. This divides into right hepatic artery, and this is the left hepatic artery. And this is the cystic artery, which is coming from right hepatic artery. Now please look at this image. This is a digital subtraction angiography of the superior mesenteric artery. This is DSA image of superior mesenteric artery. And you can see this vasa recta telling you this is a vessel supplying the bowel loops, right? So you are seeing those vasa recta. So these are mesenteric artery. And how do you know is it superior mesenteric or inferior mesenteric? The superior mesenteric artery gives branches both on the left as well as on the right side. So they give you branches on the left side also and right side also. The left side, usually we have the small intestinal branches, jejunal branches and ileal branches, they come from the left side. Whereas on the right side, we get colic branches. The right colic artery, the ileocolic artery, the middle colic artery, they are all coming from the right side. So you will see the ileocolic, right colic and middle colic coming from the right of the superior mesenteric artery. Remember, normally the superior mesenteric vein is on the right side of the superior mesenteric artery. This is the superior mesenteric artery and the superior mesenteric vein is on the right side. This is normal. But if there is midgut malrotation or volvulus of the midgut, so you will see that the superior mesenteric vein is coming on the left side and the superior mesenteric artery is on the right side if there is a midgut malrotation or volvulus. So normally you will see the superior mesenteric vein on the right side of the superior mesenteric artery. Normally the superior mesenteric artery is on the left and superior mesenteric vein is on the right. But if the superior mesenteric artery is on right and superior mesenteric vein is on the left, what does this indicate? This indicates midgut volvulus. You are seeing the twisting of the vessels, right? There is a whirlpooling of the bowel loops across the superior mesenteric vessels. This is midgut volvulus. And sometimes you may see a thrombus inside the mesenteric artery, a filling defect inside the superior mesenteric artery causing acute mesenteric ischemia. And when you have acute mesenteric ischemia, you will start seeing air in the wall of the bowel. You may see edematous bowel with air inside the wall of the bowel. This is called as pneumatosis intestinalis. Pneumatosis intestinalis. And the air may also enter the portal vein. That is called as portal vein gas. Pneumatosis intestinalis and portal vein gas. This is indicative of bowel necrosis and a poor prognostic finding. So when you see pneumatosis intestinalis, what do you mean by pneumatosis intestinalis? Intramural air, air within the wall of the bowel. Intramural air means air within the wall of the bowel. Luminal air is normal, but air within the wall of the bowel, that intramural air is pneumatosis intestinalis. And you also see the portal vein gas. And the portal vein gas will extend till the periphery. It will go towards the periphery of the liver, right? So in the portal vein and also extending towards the periphery of the liver. And look at this vessel. This is also having the vasa recta. So this is a vessel supplying the bowel loop. And does it have branches only on the right side or only on the left side? It has branches only on the left side. So you can see these branches only on the left side. There are no branches on the right side. So this vessel which is giving branches only on the left side, this is inferior mesenteric artery. This is a digital subtraction angio of the inferior mesenteric artery. And what are the branches of the inferior mesenteric artery? You get a left colic artery, you get a sigmoidal artery, and you also get a superior rectal artery. These are branches of the inferior mesenteric artery. And if you're having a young patient with hypertension and on ultrasound, you are seeing asymmetrical kidneys in the patient. You can see the image here. Look at the right kidney and look at the left kidney. Which kidney is smaller? The right kidney is smaller. And if you observe the vessels, this is the abdominal aorta. These are the renal arteries. At the beginning of the right renal artery, you are seeing a narrowing. This is basically renal artery stenosis. So, a young patient with hypertension showing asymmetrical kidneys suspect renal artery stenosis. The initial evaluation of these patients is done with ultrasound Doppler. The ultrasound will show you the asymmetrical kidneys and Doppler may find out the renal artery stenosis. If it's a very thin person, you may actually see the renal artery stenosis on the ultrasound Doppler. But the preferred investigation of choice that will show the narrowing clearly and also the collateral that have developed properly is your CT angiography. So, the investigation of choice for renal artery stenosis is CT angiography. But CT angiography is done with a high dose contrast, right? So, it is a iodinated contrast that you need to give. If the serum creatinines are elevated or the renal function test in the patient is abnormal, can you give iodinated contrast? No, you have risk of contrast-induced nephropathy. So, whenever the serum creatinine is elevated or when there is abnormal renal function test, to look for the blood vessels, what do you go for? MR angiography without contrast. What do you call that? Time of flight technique. So, what is the investigation of choice for renal artery stenosis? If the renal function tests are abnormal, time of flight technique, MR angiography with the time of flight. So, what are the things to remember about renal artery stenosis? A young person with hypertension, asymmetrical kidneys. Initial evaluation is done with ultrasound Doppler. The investigation of choice is CT angiography. If the renal function tests are abnormal, what do you prefer? MR angiography with the time of flight. And if you are having a young female patient who is showing you a corkscrew appearance or tortuous appearance or beaded appearance of either the renal artery, most commonly involved is the renal artery, or the internal carotid artery. So, a young female having either the presentation as hypertension or transient ischemic attack, showing tortuous or beaded appearance of the renal artery or the internal carotid artery. This is fibromuscular dysplasia. Fibromuscular dysplasia. So, if you are seeing this beaded appearance or tortuous appearance of the renal artery, also called as piloplate appearance, right? So, tortuous appearance, beaded appearance or piloplate appearance all mean the same, of either the renal artery or like this in the internal carotid artery also. So, either in the internal carotid artery or the renal artery, if they show such tortuous or beaded or corkscrew appearance, please suspect fibromuscular dysplasia, Now, what is this fibromuscular dysplasia? This is a non-inflammatory, non-atherosclerotic angiopathy involving the medium-sized vessels and common in young females between 30 to 40 years. The presentation can either be in the form of hypertension or transient ischemic attacks. If renal artery is involved, hypertension, and if internal carotid artery is involved, it can present as transient ischemic attacks. And the classic imaging finding, remember, tortuous or beaded appearance or piloplate appearance on angiography. And if you are given a question where there is an elderly male who is having hepatitis B and is having P-ANCA negative vasculitis, and on the imaging you are seeing multiple renal artery microaneurysms within the interlobar and arcuate branches of the renal artery, you are seeing this small renal artery microaneurysms. You are seeing renal artery microaneurysms. What do you suspect? This is suggestive of classically polyarteritis nodosa. The most common artery involved in polyarteritis nodosa is renal artery. Let's learn some important points about polyarteritis nodosa. Polyarteritis nodosa is an inflammatory necrotizing vasculitis involving small to medium-sized arteries. The condition is more common in elderly males, and 30% of the patients are also with hepatitis B antigen. So, very strong association with hepatitis B. And the most common artery involved in polyarteritis nodosa is renal artery. It's a P-ANCA negative vasculitis. And what do you see? You see this classic renal artery microaneurysms in the interlobar and arcuate branches. Within the intraparenchymal branches of the kidney, you are seeing this renal artery microaneurysms in case of polyarteritis nodosa. So, if I have to sum this up, imagine this is the aorta, this is the renal arteries. If you see beaded or tortuous appearance of the renal artery like this, or within the intraparenchymal branches, you are seeing this microaneurysms. So, if you see a narrowing at the proximal portion of the renal artery, this is renal artery stenosis at the branch point at the very beginning of the renal artery. You see this narrowing, this is renal artery stenosis. And if you see a beaded or tortuous appearance of the middle to distal part of the renal artery, this is fibromuscular dysplasia, the corkscrew appearance. Whereas within the intraparenchymal branches, if you see this microaneurysms, this is polyarteritis nodosa. So, remember this diagram. So, you will remember these three conditions: narrowing at the proximal portion of the renal artery, that is renal artery stenosis; corkscrew or beaded or tortuous appearance of the renal artery is fibromuscular dysplasia. And if you see renal artery microaneurysms, that is polyarteritis nodosa. And can you tell me, where do we see the coronary artery microaneurysms? I hope you remember, coronary artery microaneurysms are a classic feature of Kawasaki's disease, right? And if you see, there is a poor perfusion of the major vessels of the limbs. There is poor perfusion of the major vessels of the limb and multiple corkscrew collaterals on angiography. You are seeing this corkscrew vessels on angiography. This is a smoker with limb claudication, ulcers on the limbs. There is poor perfusion of the major arteries and multiple corkscrew collaterals. This word is important. Corkscrew collaterals on angiography. This is suggestive of Berger's disease or thromboangiitis obliterans. Please remember, Berger's disease or thromboangiitis obliterans will have corkscrew collaterals on angiography.